Welcome back. Thank you for joining us on The Explainer tonight. Like we said, we are speaking about UHC and access to SHA and all of the services that are provided by the Social Health Authority. We shall be speaking with both Dr. Mercy Mwangangi, who's the CEO of the Social Health Authority, as well as Engineer Anthony Lenayara, who's the CEO of the Digital Health Agency. But for this quick fire round, we are joined first by Dr. Mwangangi, and we invite your questions. The hashtag is The Explainer at Citizen TV Kenya and at Yvonne Okwara. Any questions you have about this, whether you're a service provider or you're a customer or a client seeking services at a hospital, please do send them in. We'll endeavor to get as many of them answered as possible. Dr. Mwangangi, thank you very much for making time for us tonight.
Thank you, Yvonne. Thank you.
Let's start with the general perception. Even when we put out the announcement that we were having you tonight,
yes,
many of the questions are about SHA not working. They've gone to the hospital for various reasons, both from service providers and from patients. There seems to be a general perception that SHA isn't working. Is it working, Dr. Mwangangi?
Thank you, Yvonne, for having me. And I was just looking at my phone right now and calculating. I joined SHA on the 3rd of June, and today marks 105 days since I joined SHA as the CEO. This is actually also the first engagement I've had in being able to talk to millions of Kenyans and explain to them what exactly SHA is. You've asked me, is SHA working? And I would say, yes, SHA is working. But I'd want to add on to say that perhaps what we need to do and how we have value in this conversation tonight is in explaining to Kenyans what SHA is. And you'll allow me to share a story. 2 weeks ago, I went to SEK Mbere for church service on a Sunday. And I sat next to the Mother Union president, and they were having a function celebrating mothers at the church. And when I was talking to them, one of the ladies sitting next to me asked me, what is the difference between SHA and SHIF, right? And I know a lot of us have been using a lot of jargon there. We hear people saying SHIF, SHA, SHISHA, even using that comically. And I'm here tonight to explain to Kenyans what exactly SHA is. SHA is an authority, and SHA has 3 funds within it. And that's really important because if you compare and contrast, and I've heard a lot of people saying NHIF was better or NHIF did this, SHA is doing this. One of the pivotal things that government did is to be able to set up 3 funds within one. And we have to ask ourselves, what were they trying to cure? Why set up 3 funds within one? And the first thing is that there was need for us to invest in primary healthcare services for all Kenyans. And I must say, I've been a health economist for 15 years, and I've worked in different administrations in the Kenyan government. And I can tell you, for the first time in Kenya, we actually have an investment in primary healthcare services. And Yvonne, this is why it matters. It matters because 85% of our health needs are catered for at the primary healthcare level. And so if we're going to have a scorecard on whether SHA is working or not, we need to ask ourselves, has SHA made an investment in primary healthcare services? And the answer is yes. And we have the numbers to back it up. I was looking at our data today, and when we look at primary healthcare services, in terms of providers, we have 9,000 facilities. 9,000, Yvonne, providing PHC services to Kenyans. When we look and ask ourselves how many Kenyans have accessed these services, we have 5.5 million Kenyans in 10 months who've walked into a primary healthcare facility and accessed a PHC service. And when we look at our visits and counts that we've reimbursed, we've pushed into the primary healthcare system close to 8 billion. Now, Yvonne, why am I excited about this? I was serving in government 4 years ago, and I do know the budget that was available for primary healthcare services then was 1.9 billion Kenya shillings. And in 2 years, this number has gone up to 9 billion Kenya shillings. And when you unpack this, for the first time, we have Kenyans saying, before, in the NHIF model, I had to be placed to a facility. Now, in the SHA PHC model, I'm able to decide which facility I'll be able to seek services from. We used to have mechanisms where Kenyans would be told, go to that facility there, and yet that Kenyan would be living in Nairobi, but they've been capitated to a facility in Meru and told that is where you go and access your service. all that has changed with SHA. And so when we look at primary healthcare services, 8 billion injected into that space, a budget of 13 billion that's available this year.
So this 8 billion is for this financial year, this current financial year?
For this financial, we've been able, so since the inception of SHA in October to date, we've been able to pay out close to 8 billion Kenya shillings. If we look at the new financial year, Parliament has allocated 13 billion Kenya shillings for primary healthcare. Yvonne, it used to be 1.9 billion.
And how much?
Now 13 billion.
How much has been paid out for this current financial year?
So in the current financial year, we've paid out about 2.9 billion because I think we're only 2 months into the new financial year. So for this quarter, that's 2.9 billion. And you know, Yvonne, one of the criticisms I've heard people say is that, you know, we've become very good at reporting numbers, payouts. But I want you to narrow down and look at the figure of 5 million Kenyans who've walked in to a health center, who've walked into a dispensary, who've walked into a level 4 hospital and accessed care and walked out without paying for that care. And I think the president has pronounced himself several times that Kenyans will be able to walk in and walk out from a level 2, a level 3, a level 4 outpatient facility and receive care. And that's happening. And that's profound. 5 million Kenyans served. So in that regard, I would say SHA is working. Now, when we walk through the Kenyan who's accessed their PHC levels, PHC level of care, received service, but requires more, then in comes what we call the SHIF fund. Yeah. And I say today, I really want to go home and sleep well, having demystified to Kenyans what SHA is. It's 3 funds. The first fund takes care of your primary needs. So that's the PHC fund. And right now, like I've told you, you have an allocation of 13 billion. We've paid out 2.9 as of today. And we intend to go back to Parliament in supplementary processes and get at least another extra 7 billion. So by the end of this year, we'd be having 20 billion for PHC. Now, what happens when your cares are not taken, when your needs are not serviced at the primary healthcare level? In comes the secondary level of care. And the design of SHA was very deliberate, very, very deliberate, in that we needed to ensure for the services that Kenyans need the most, which is 85% of our health needs, those can be served at the primary healthcare level, right? And when I've shared with you that 5 billion Kenyans have accessed that, the 2.26 million Kenyans that we keep talking about that have been registered into SHA actually have access to that primary healthcare level. If you're registered and expect that you are because you work for Citizen, then you have free choice of going to a level 2, 3, 4 facility and accessing care, walking in and walking out. So what happens when Yvonne perhaps needs a knee surgery, right? So a knee surgery would not ordinarily be available in a health center or a dispensary. You would have to go to a specialized facility, a secondary care facility. If you have to then go to a secondary care facility, then in kicks in what is known as a contributory fund. Yeah. And for that, you would have to either give us 2.75% of your income if you're in the formal sector and you're employed. And if you don't have a pay slip, then you'd have to go through what we call means testing, which determines your premium. And I know there's a lot of noise on means testing, and I'll be demystifying that shortly.
And we will get to that.
We'll get to that. Yeah. So you then go under means testing process. Your premium is determined. You pay in your contribution into the fund, and then you're able to access services. And one of the things I've been listening to the shows and really doing a lot of social listening to understand what are the pain points that Kenyans are having. And one of the things that is causing a lot of lack of understanding is the thinking that 25 or 26 million Kenyans have registered, yet X amount have paid into SHIF.
All right, so let's understand that. How many registered on the portal? How many have registered with SHA?
I will answer that. But to answer that first, I want you to understand and to allow me to really demystify the authority, because I haven't talked about the third fund. It matters. It matters.
All right.
It matters, Yvonne.
Yes, and I'd like us to do that as because
you want me to move quickly?
Many questions.
Many questions. We'll answer all the questions. I have all the night for everyone today. So the third fund is the emergency fund. Right. The Constitution says every Kenyan must access emergency services. And so a fund was set up that allows Kenyans to be able to go into the facility and get 24-hour care, and to also get evacuation services. The design of the Social Health Authority is really a game changer for this country. And I want Kenyans to hear me, and hear me right. The design, the blueprint is right. What we are working now is on implementing this blueprint and ensuring that it's able to serve us. But the blueprint is right. Now, when you ask me how many Kenyans are registered, as this morning, 26 million Kenyans have been registered, have self-registered, presented themselves and registered into the authority.
All right.
Now, Yvonne, because your next question is one of the myths that Kenyans are suffering on. Kenyans are saying, yes, 26 million Kenyans have registered into SHA. How many are paying into SHA?
Okay.
And that question is important because it means that we need to demystify this whole project in terms of how we've designed it.
So those who are registered at 26 million.
26 million.
Yes. How many are paying? Let's start. In total. 26
million Kenyans are registered. 26 million Kenyans can access PHC services for free.
Yeah.
That's really important.
Understood.
Now, out of the 26 million Kenyans, we have Kenyans in the formal sector and the informal sector. In the informal sector, impressive data, we have 800,000, so 887 Kenyans who are in the formal sector, non-pay-slipped Kenyans who've paid in for SHA. So if I open the system right now and ask myself how many Kenyans do not have pay slips and are paying into SHA, we are close to almost 1 million Kenyans.
Okay, and how many...
When we look at the formal sector...
How many is salaried?
4 million.
So that's 4 million?
Yes, 4 million plus 800,000. So that's about 4.8 million Kenyans who are paying into the contributory fund, meaning those 4 million Kenyans are the ones who then have access or eligibility for that fund.
All right, sorry, let's understand. 887,000 non-salaried?
Yes, non-salaried, yes.
And the salaried are how many?
About 4 million.
4 million.
Yes.
We had one of your staff here just yesterday in the morning who talked about 3.3 million in the formal sector who are salaried. Has that number since jumped by...
So I want to explain to you how we do...
600 million over the last 24 hours?
Not a problem, Yvonne. I have the system right here and I'll be able to share with you the figures. So how we do our formal sector contributions is that we have self-declarations from employers. So you, for example, in Citizen, whoever heads your HR department will be able to come in and say, Citizen Media House has 10,000 employees registered, earning these salaries, and therefore 2.75% deductions of these 10,000 employees is equals to X amount. And so the figure keeps changing. And so when we average out our figures, we have about 4 million formal sector contributors coming into SHA.
These are 4 million people with
4 million, yeah, 4 million, let me call it 4 million pay slips. Yes.
How many people are actually salaried in the country based on data from iTax?
So,
because that number would be about 3.3 million.
Very good. So you have, in fact, one of the things that's impressive.
4 million.
Yes. So how we categorize a formal employer in SHA may be a little bit different from how KRA would categorize this, and I'll share this with you. SHA actually has more declarations of Kenyans who are saying, I have this little SME that I'm running, and I have 5 or 10 employees in this SME that I'm servicing.
But those are not salaried.
No, they are. So, for example, if you run a kiosk, right? So you have your kiosk, and you have your employees, and you're paying into SHA, you come in and you self-declare that in this little kiosk or in this little supermarket or hotel of mine, I have 2 cooks, I have 10 waiters, and these employees are the ones who are going to pay according to the pay slips that I'm generating. So SHA actually has more data than KRA when it comes to contributions into the fund.
So this is an improvement from the numbers that were given on the show yesterday morning, which is at 3.3 million. I'm just trying to understand that.
So I know you're...
That's a huge...
No.
That's a huge gap.
I know you're saying that, hey, have 600 people suddenly joined within 1 month.
No, within 1 day. Because these are figures that were given on Daybreak that was hosted by my colleague here yesterday.
I'm here sitting with our collections. And it's okay. The colleague may have made an error in numbers.
So we go with
we
your
do
figure
have our
of 4
data.
million.
Yes, we do have our data, 4 million people. And Yvonne, you've raised an important point. When you think of industries, right? So look at the hotel industry. If I was to ask you, could you enumerate for me, even from the iTax data or even the KNBS data, what the hotel industry figures look like? SHA actually has numbers because Kenyans are demanding that health service, and these employers have actually declared these people as their employees and are actually paying into the fund.
Okay. Yeah. So 4 million salaried, 887,000 non-salaried.
Yes.
How much is the contribution, let's say, as of today?
So in our collections to date, and I was just sharing this with the Governor of Moranga, who's going to one of your stations here, that in the lifetime of NHIF, total collections that NHIF ever made actually touched around 45 billion Kenya shillings. To date, SHA has been able to receive close to 8 billion for the Primary Healthcare Fund. We've been able to receive close to 5.9 billion for the Emergency Chronic Illnesses Fund. And then we've been able to get collections of close to 54 billion for the SHIF Fund. So if you add all that up and look at also the Public Servant Scheme, which we recently received 4 billion for, as well as indigents who are covered by government. We have about 500 million and 30 million for orphans and vulnerable groups. Our collections to date almost stand at almost 70 billion. Okay,
let's talk about SHIF. Just how much collected from SHIF?
So SHIF, on average, from October to date, we started averaging around 6.5 B every week collected.
6.5 billion per week.
Yes, and per month, so it's from October.
Yeah.
So in October, our collections are a little bit low, and they've been tiering up to about 6.5, 6.7, 6.8, 6.9
so now,
B.
If we say
right
we're
now,
at 11 months?
At 11 months,
yeah,
close to almost 50 billion plus collected. Yes, and I'll confirm that for you right now. Yes.
And what are the claims?
So when we look at our claims, one, I'll start again with the Primary Healthcare Fund.
No, let's just focus on SHIF for a minute. We will talk about the other funds. I'd like us to focus on one by one.
Okay.
So SHIF, you said an average of 6.5 billion
An average of 6.5 billion collected a month.
Okay.
And as I share with you the number of claims, it's important to be very clear on this, because I've seen a lot of your panelists come in here and say X amount of claims submitted. A claim submitted to SHA is not equals to a claim approved. Now, if I look at the claims submitted for the month of August, no, I'm going to get into it. No, I'm coming there. By the way, Yvonne, full disclosure tonight, we will share with you everything that you need.
So
in terms of our claims
that have been made,
right?
Yeah.
So in terms of claims that have been set into the system so far, they come to around 80 billion.
Okay.
In terms of claims, 82 billion. Those claims are claims submitted.
Okay.
Now, for SHA to actually pay out a claim, it has to go through verification. Some of those claims, Yvonne, will be approved for payment. Some of those claims will be rejected with various reasons. Some of those claims will be sent back to the provider for additional documentation for us to be able to make a decision. So when we look at our servicing of providers, of all the claims that have been lodged to date, our contracts actually state that our providers should be serviced within a 90-day period. Where are we today? We're close to almost, so let me categorize this into ownership. For public facilities, these are county providers. We've settled their claims to a rate of 69 to 70%. When we come to FBO facilities, they range between 65 to 69%. When we come to private facilities, they range on the lower band of 65%. And if we look at the fulfillment of our contracts, which should be fulfilled within 90 days, we'll be able to say that most of our facilities are within that 90 days, and a few are above those 90 days. Those that are above 90 days, Yvonne, may be having claims that are rejected, may be having claims that have missing documents, may be having claims that need to undergo surveillance. And it's important for all of us to understand, claims submitted is not equals to claims paid outright. So let's talk about some of those claims that have been rejected. How much, in terms of claims, has been rejected by SHA? So to date, we have rejected 10.7 billion. 10.7, okay. And could you inform us the status of the investigations now? Because we understand those are we'll get into that. Oh, yes, we'll get into that. So not a problem. Yeah,
let me just understand. Let's go. We'll go step by step. That's fine. So 10.7 billion has been rejected with allegations of fraud. Can you tell us, break it down by facilities, like just the way you've done in terms of public, private, faith-based? So fantastic. So when it comes to fraud, I want us to all understand the insurance industry
particularly medical insurance industry, has a rate of almost 20 to 30% of fraud globally. Let that sink in, Yvonne. Globally, not Kenya, not Uganda.
All right.
No, it's important because
Dr.
I'm coming to your answer.
Yes, I would like us to also just move it along. So out of the 10.7, let's just answer the question.
Yes.
Please break it down.
Yes.
How much of this was from public facilities, from faith-based, and from private?
So, Yvonne, I'll come
before we get to the global statistics.
No. But global is important.
That's fine. We can set the context after. The whole idea of how that verification process is done is a topic on its own, and we will come to that.
Okay.
I'd just like us to go step by step first. This 10.7, could you give us the breakdown? We will come back and understand the verification process.
So, out of the 10.7 billion, I do not have figures that I'll give you right now that public facilities is X amount, FBO is Y amount, private is Y amount, because this is a continuous process. For example, as the team has been doing their claims verification today, we actually have a new set of 80 facilities who've been discovered to be fraudulent, and we'll be releasing that this Friday.
Okay, is this separate from the 10.6? Because I just want to understand that one first.
So every time a claim is lodged, every claim paying season, we actually determine a claim that is fraudulent.
We'll get to those ones. I understand it's a dynamic situation that evolves.
So now,
can we just speak about the 10.7 that you talked about?
Yes, and let me break it down for you. You've asked me how much is due to or attributable to the private sector. I can tell you the number of facilities, but I wouldn't be able to tell you in proportions.
Okay, how many facilities?
Right? So right now we've submitted a list to DCI of 1,118 facilities that are under investigation. 1,118 facilities.
Okay.
Out of that list, 85 of those facilities have been blatantly determined to be fraudulent, and there's a criminal investigation that's going through the justice system. Out of those facilities, we have about 100 and I think it should be 51, and I can always give you a written statement with these figures later, of facilities who also have been determined to have fraudulent claims, and particularly trading in tiers of care which are not appropriate to their licensure. Okay. Right? And so all these facilities have been submitted to the DCI. I'll come back, or I'll share with you a statement on what the proportions look like per ownership. That we can do later.
And can you tell us the progress of the investigations of the DCI?
The progress is underway. Teams have been able to visit different facilities. Just today, I got feedback from that team that they've gone to different parts of the country. The 85 facilities I've talked about have been visited. They've gone in, they've looked at their files, they're investigating, and they should be able to share with us a report within the next 10 days. Okay,
some of the service providers have raised concerns about data privacy for patients, particularly from the DCI, who are then, going in and seeking, doctor's notes, as well as private patient information. In what way are you preventing, patient, or rather upholding patient confidentiality in an investigation such as this, because there is a huge concern around that?
So we've actually received that feedback from providers in two manners. Some providers have come in to say, no, we don't want to attach our theater notes to your claims because that's infringing on patient privacy. One, our act actually allows SHA to be able to engage with patient data, and patients do actually give consent by visiting the facility and by filling in claimant forms to be able to have SHA access that data.
But that does not extend to the DCI,
No. When it comes to our contracts implementation, DCI actually has that in our law. If you do commit a fraudulent claim and submit into SHA, there are actually contractual terms that govern what SHA would do, including fines, including criminal prosecution. That's actually in the Act. Now, the data that then DCI are able to have is then governed by the data protection of our Act, as well as the DHA Act that actually protects that patient data.
Okay.
And so it's all protected, it's all within the law. No data will be shared. And remember, DCI have been doing these investigations years back. Even during NHIF days, DCI was still very active investigating. There's no way, and I want us to be very clear, there's no way we will know if this claim is legitimate if we are not able to assess the claim and determine that the surgery took place, that the birth or the delivery took place. How would SHA pay? On trust? Is that what we'd be doing? Paying on trust that the doctor did the procedure? We can't. And no insurance company does that. globally.
One quick question before we take a break, because you say SHA is working. The service providers seem to hold a different view.
True.
Let's talk about RUPA, which is the Rural Private Health Association practitioners. They have a countdown. By Friday, they say they will be suspending SHA services. They're asking you to speak with them. They're saying you are not talking to them. They have many facilities under this umbrella association. Could this be a potential public health access crisis? And what are you doing about it?
That's a really good question, and it's embarrassing when they say that we're not speaking with them, because just in the last week, I've actually met the Association of Private Hospitals in the hospital, I mean in the SHA building, to be able to discuss provider issues and what they're facing. Yvonne, it's almost, how do I say, sacrilege for a provider to decide to pull out of a contract that they've gotten into SHA and not offer services into Kenya. Our contract actually states very clearly that if a provider backs out from the contract and rejects a Kenyan from visiting their facility, that's actually a contractual flaw.
So are there calls valid? No, we'll get to the contract.
Wait, you've asked me, are we engaging with RUFA?
Are you?
And the answer is we are engaging with all providers and all hospitals, because our contracts, Yvonne, the contracts I have in my system are with specific hospitals. There's no hospital that has come in to SHA and has been turned away or not engaged. And that's important for us to note. Number two, every provider in the country has a right to exercise their contract and to decide if they want to offer service or not. If they withdraw service from Kenyans, then that's a move that they've made in terms of their contracts. And then SHA would have to then withdraw engagement with them.
All right, okay.
Yes.
As we go to a break again, 6.5 billion is collected on average?
Yes.
For the last 11 months?
Every month. Well, in the beginning, as we were trying to, bring in Kenyans, the collections were not as high as 6.5 billion. By the time we got to February, March, April, they stabilized around 6 billion. And I was just sharing with the governor from Murang'a, we are close to hitting 8 billion in collections.
So from March to date is how many months? March, April, May, June,
March, April,
July.
May, June, July,
August.
So
that's
August
6
has just come to an end. So in August, our collections are above 7 billion.
So 6.5, if we did that times 7, right, that would be 45.5 billion.
More.
At least, at least for these last. So where would you put it at?
I would say probably above, I'll check for you right now as you get into your break, but above 50 billion, which is remarkable.
Okay, because an average of 6.5 billion for 11 months is more than 50 billion.
Exactly. I'll just pull it out for you, Yvonne, shortly.
Okay.
Right now.
We'll come back. We have lots to talk about.
We have a lot to talk about.
Let's take a break. When we come back, we'll also be speaking with the CEO of the Digital Health Authority to get an understanding of how they both work and the services that they are providing to Kenyans. Welcome back after the break. So let's take that break now. Where do we take it? Here or there? There we are. There we are. So let's take that break now. Back in a moment with some more news, and then we're back with this discussion on access to health services via SHA.